the rest of the world, right? Yeah. They and Ada County, incidentally, is kind of leading the way. You know, the Ada County paramedics is the name of them. They're all not all paramedics. They're different levels of training for paramedics, but it's so much easier to explain to someone. You know, it's like being a nurse, right? Say, I'm a nurse. And then there's other questions that go along. This is what level of training do you have as a nurse, but you're a nurse. And it'd be that much easier if we were paramedics, if we just called everybody paramedics too. They do it everywhere. In Canada, everybody's a paramedic. We're one of the only countries in the world that don't call all of our pre-hospital care providers paramedics. It's just easier. And
Well, if they were all trained to the same level.
yes, there is.
Thank you. I'm not touching people with the mark.
There you go. Here's one of my cards. Linda was going to be here, Linda Ramler.
She's not ill today.
Okay. So you're separate. Who else, Chief, are we waiting for?
Home health, was it Terry from home health?
No, me.
Oh, it's good.
Okay.
So Linda's just out ill. I was representing home health, but
Home health and hospital and, okay. Good, good. Well, we just want to get a lot of as many as we can, but since it's 5 after, maybe we
Next
should
Tuesday?
start.
I'm here.
In the library and Sandpoint Urgent
In the
Care.
library?
That's a very good cross section.
Okay, great. So maybe you can introduce yourself. I'll start with me. Okay, I'm Mark Zandhusen. I'm a captain with Bonner County EMS. My job is clinical operations of Bonner County EMS. So I have a little bit to do with the clinical operations. I and Dr. Jenkins kind of oversee the whole thing. And then there's Chief Wakely that's with us, Chief Rob Wakely, and Dave Ramsey, Captain Dave Ramsey. Dave is Chief, of course, is in charge of everything. But Dave is in charge of our wilderness and training section. And he is also, we've had 3 paramedics go through specialized community paramedicine training through Hennepin Technical College in Minnesota. And it was myself and David and the other captain, Jeff Lindsay, who went through that training. We're still right now in the process of finishing up some of our clinicals, but it's pretty cool stuff. So, and then we have you, sir.
Gary Robertson, actually Mark Hernandez, Dr. Tyke asked me to come and see what was going on. And also I'm representing Bonner County Partners in Care. So clinic, which free clinic for want of a better term.
Great. We just mentioned that. I talked to the medical staff at BGH this morning. Were you there?
Nope.
There was mention of that. One of the physicians there said that would be a good contact for me to get a hold of, because we just mentioned that. I just presented community paramedicine to the medical staff at BGH this morning. So.
I'm Ann Nichols. I'm the director of the library here in town. We distribute information, so anything that you can get to us, we can get to the community.
And that is specifically why we invited you.
Oh, great.
Yeah. Yeah.
Okay.
And I'm hoping that all of you, as you listen to this, will say, wow, this is why I got invited to this meeting. This is why we want this representation at this meeting. So very good. Welcome.
I'm Desiree Johnson, Clinical Operations Manager at Connexing Health Services.
Very good. Desiree, have we talked on the phone before?
Probably already talked to Mary.
Okay, well, welcome. And really, the outlying clinics and things like that, I like to call them safety net clinics because they are a safety net clinic for the community. That, you know, very important to get your input on these activities that we're talking about.
Amber Moyer with Area Agency on Aging. Do case management in Bonner and Boundary County, and then adult protection as well. And Jennifer couldn't be here at the last minute, sorry about that.
It's okay. This was a last minute kind of thing. But, well, welcome. Very important, because that's a huge cross section of the patients that we take care of, that we see out there, and the ones that we're going to talk about when we talk about community paramedicine.
And I'm Tammy Fan. I'm the manager for Bonner General Hospital Home Care and Bonner Community Hospice, and we serve both Boundary and Bonner County.
Excellent, excellent. And your input is invaluable. We just need all kinds of input from you, because we're not, one of the first things that people say, Mary, come on in if you want.
I just want to make sure that Amber showed up. Oh, yeah.
Because one of the first things that happened whenever I start talking about this, talking about community paramedicine, is even the physicians this morning said, gosh, this sounds like home health. And I said, well, you know, it does sound like home health, but it's not home health. We are really not in the business of trying to take a job away from anybody. What we're trying to do is just use untapped resources to meet unmet healthcare needs. So people that don't qualify for home health, people that don't qualify for hospice, people that don't qualify for many different programs, there's a small little niche out there of patients who we think we can help. Okay? So I'll just get, do you have any questions so far? I want you just, this is really informal, okay? Can we do this really informal? If you have any questions that pop up, just ask away, all right? And if you don't mind, the reason I'm asking for your email and your phone number is because I would like you all to be the beginnings of a stakeholders group that I would like to meet from time to time to get input on what we're doing, okay? Because we need input from, you know, small communities survive based on collaboration, and that's what we're trying to help. Is we want to help collaborate. We want to utilize some of our skill sets to help meet some of these.
Mark, before you go into the presentation, can you talk a little bit about the grant from Health and Welfare and our primary mission for this meeting? That there are 2 reasons for us being here.
There are 2 reasons. The first, one of the reasons is that I want to introduce community paramedicine, the concept of community paramedicine. And then as we, actually I was going to talk about community paramedicine first and then go into the pilot projects that we're getting funded. And one of the pilot projects, the first ones that we got funded, is the hypertension project that we're working on. And the hypertension project is through the state hypertensive and totally lost my train of thought there. It's through the hypertension project from the state. April Dunham has given us a small mini grant to close the healthcare loop and try and get some community paramedicine going with specifically to blood pressure checking. And what we're doing right now is we've got 2 things going on. We've got a blood pressure, we call them clinics. They're not really clinics in the sense that you guys know clinics, because we don't do a whole bunch of stuff. What we do is take blood pressure. So we go to the senior center here, and we take blood pressures every Thursday in Sandpoint. We see 150 patients. We have 150 patients in a little Rolodex there of recorded blood pressures of them. We do that once a week. We do that same thing in Priest River. We see 75. We have 75 patients in Rolodex. And I'm telling you that some of these patients are your patients. Some of these patients that we're seeing are your patients. Some of these patients that we're seeing are patients that you are trying to manage their blood pressure on. And they're using us to come in and get their blood pressure taken. So we come in currently, this is what happens currently. They come in and we visit, we say, how you feeling, Mr. Jones? We take the blood pressure, and then, gosh, your blood pressure is kind of high, Mr. Jones. You should probably see a doctor about that. Next! And that's pretty much how it goes. We make them think about their high blood pressure. We ask that they go see a doctor. I mean, of course, if it's really high, or we detect any other problem going on, we'll transport them to the hospital or take care of them. We're not going to just turn them loose. But what we're hoping to do with that is identify those patients that are there that meet hypertensive criteria, figure out who their primary care person is, work in concert with that primary care person to treat that patient, and then we'll be the people who are taking their blood pressures. You'll have the advantage of getting that blood pressure taken by the same equipment on the same day every week. And then we'll take that information, report it back to the primary care practitioner, and then thereby closing the healthcare loop. And that's really what our grant is all about, to help develop a process that we can close that healthcare loop right now. Like I said, it's a small little grant. It's the beginnings of community paramedicine. Question?
How big is the grant?
$11,000. So it's basically just paying for my time.
See, we also have a grant, and it's through, I think it's all of the area agencies. I'm not sure for Northern Idaho or for Idaho, but it's a med management and we go in, when we're doing our regular home assessments and things like that, we gather up all their medications, write them down, write their doctors who prescribed them, the date it was dispensed, take their blood pressure. And then I'm not a nurse, I'm a social worker, so I bring it back, I put it into a website, and hopefully the guy at Interlake Pharmacy contacts the doctor or something like that. So I can see where there's, it's not a full circle, there's always kind of a hole.
Yep,
For people
and that's
that are
the gap.
trying to help.
And that's the gap. That's the gap that we want to try and help fill, and that's where we think EMS is an untapped resource. We have highly skilled, trained paramedics. And when I say paramedics, please bear with me. I say all of our team. I just refer to them all as paramedics. But these guys, they're highly skilled, and they have skills that are useful to you as primary care providers. Question?
I'd like to ask questions.
Sure.
How is the money allocated? In other words, where can you use your money?
This grant is just for my time, pretty much. That's pretty
My
much.
time.
Yeah, our time, the time that we're
and
putting into
educational materials.
developing these materials that we're going to use.
For some reason, it doesn't allow us to buy medical equipment, so Bonner County EMS is buying the blood pressure cuffs because the grant wouldn't allow us to do it. But basically, we're going to be charging for educational materials that we produce. We're going to produce video, an educational video, Mark's time and my time spent on the project.
And I've got a few forms that some referral forms and things like that I've come up with, and I want to share them with you. I would prefer to email them to you. I'll put them up on the screen if you want. But I prefer to email them to you, get your input on them, and then we can email them back and kind of handle it that way. Would that be okay? But basically, it's just a form that the paramedic's going to use. We could even get referrals from the field eventually. In other words, paramedic goes on scene, takes care of the patient, takes their blood pressure, and everything's, and they are hypertensive or they qualify for that hypertensive, then the paramedic could fill out another form and refer it to the community paramedicine, and we could do a visit that way. Make sure they've got primary care providers. The idea behind this is it's a way that we as a community can adapt to all this healthcare reform stuff that's going on. Okay? I mean, on a national level, I'm participating on a national level and a state level with all this stuff. Let me go through my real quick little slide set here because I'm so proud of it. And then I want to revisit our hypertension project. Okay, so community paramedic basically is finding those healthcare gaps and trying to fill them with the paramedics. Now it's on your clinic. What did you do, Dave? There you go. So the concept is just that, and what we want to do is we want to expand the role of paramedics. So, for instance, what do you think of when you think of paramedics? You think lights and siren. I'm thinking you call 911 and you're getting the paramedic on the other end of that, right? The paramedic's going to show up. Well, and that's what most people think. But what do we do in between 911 calls? What do you suppose? Well, we have a lot of time to think. So we think up stuff like this. We have a lot of time to think, and we could better utilize that time helping the community in other ways. So that's what we're trying to do. We're not trying to expand the scope of practice of paramedics. We're just trying to expand their role a little bit. So in rural communities, people really rely upon each other. And especially in the niche areas that we're talking about are small areas like Priest Lake, or even smaller than Priest Lake, where we have volunteer QRUs, we have volunteer EMTs. And in that particular community, in many cases, that ambulance or the EMTs that volunteer for that ambulance is the highest level of medical training in the area. So what do you suppose those people do? Those people, do you think that they call their doctors? Do you think that they'll drive from Priest Lake all the way down to even Priest River? And no. There's people up in those woods that we don't see in the wintertime. We see them. We see them when their CHF exacerbates so bad that they can't make it in anymore. We see them when, when they need to call 911. And what we'd like to do is maybe see them before that and help keep them out of it becoming a crisis. So the highest level of training in that community, medical person in that community might be the EMT. So the EMT, so they call, hey, I know Bob, can you take my blood pressure today? I'm feeling it's feeling kind of high. So maybe Bob goes over, he takes the blood pressure, says, yeah, your blood pressure's kind of high, you ought to see the doctor. And that's the end of it. There's no closure in that. So And also in these areas, community paramedicine type activities really have been ongoing in these areas, just like that. That EMT will go over and he might, talk to somebody or they'll come into the station and people come into the station want their blood pressure taken and things like that. There's no really mechanism for us to assure that they're getting care for their blood pressure or care for whatever ailment they're coming in with. We do blood pressure checks all the time, just like I was talking about in Sandpoint and Priest River. And we do welfare checks all the time. The post office calls us and calls dispatch and says, gosh, Mrs. Jones hasn't picked up her mail in about a week. Maybe we should get somebody over there. So they call us. We snowmobile in, or we snowshoe in, or we take whatever means necessary to get into that patient and find out what's going on with them. And sometimes it's just Mrs. Jones hasn't picked up her mail in a week. Sometimes it's a lot worse. So the paradigm for EMS, for emergency medical services, and what we do is kind of shifting a little bit. It's kind of shifting a little bit. In the last month, the National EMS Management Association surveyed all their members. This is J. Fitch & Associates, a large firm out of Los Angeles. And they found that over a third of their respondents were thinking about community paramedicine or had got something going. 45 of them said, and another 45% said that they were thinking about doing community paramedicine. So that means that the paradigm is shifting. There's a lot of EMS people out there thinking about it. Currently, Ada County is with us, and we're doing some collaborative work together. And in that, we're trying to keep the same data set so we can maybe publish this stuff. But anyway, it really is shifting. There's a lot going on. The concept has been around for a long time. It's been around since 2006. 2006, it was mentioned in the Rural Healthcare Agenda for the Future that was put out by NAMSO, the National Association of EMS Officials. And what it starts with is taking like the blood pressure of the community or the pulse of the community and finding out where the gaps are, and then trying to find the gaps and fit us into those gaps to try and help. Not displacing anybody who's already doing the work, but helping us. An example, Home Health in Ada County. Home Health in Ada County is making referrals to the Ada County paramedics for their community paramedics. And it's because, they go into some areas that are far more dangerous than the home health care people would like to go into. So we do this all the time. So we can't go see at the heroin house, right? We can't go see that drug dealer's mother because it's too dangerous, but we can go in there, right? So they're making referrals to us. They're seeing some of the patients that they don't want to see. This also comes with additional education, and the community paramedics always have medical oversight. This is Dr. Ron Jenkins. You guys probably heard of Dr. Jenkins, world famous cardiologist, internationally famed cardiologist. So that's the training that we've gone. We did a course through Hennepin Technical College, which is the only one of two in the whole United States that offers the community paramedicine program. So we did these college-level courses on how to do a little bit more primary care. It opened our eyes up, don't you think, David? Yeah,
Very much
it's
so.
really opened our eyes up. We'd never even heard of a motivational interview before. Paramedics are the ones that go, you gotta do this, and that's the way it is. We were never the ones that tried to coax people to change their behaviors. And we learned a little bit more about doing that. So the success to this program is really based on you. It's really based on the stakeholders that are involved in this. The more people that we get involved in this, the more stakeholders involved in this, and form partnerships with, that is going to mean success or failure for this program. And really, all the stakeholders is people who are interested in the well-being of the residents of the community, and that's you guys. We did, as a capstone project for our community paramedicine course, did a community health assessment of our own. And we just utilized data that was available out there. And what we came up with was some of the healthcare gaps that we found. And what we found were patients with no insurance. Is that a surprise? No. And patients who have no transportation to get to the primary care. There are frequent 911 callers, not as many as maybe in Ada County, but these are these same patients who are doing recurrent ER visits. And also in these areas, we found that sometimes rural EMS, our people doing EMS, are the only medical care in the area that's convenient to them. So we're hoping that we can fix that. We call that the paramedic paradox. Because the further that one moves from a hospital, more likely that paramedic skills are going to be critically needed, right? And then the further you get from a hospital, the more rural the setting becomes, and the more rural the setting, the less funding is available for paramedics to be in the area. So we're hoping by doing some of these community paramedic functions, that we can put paramedics in rural areas too, thereby increasing the quality of care in that area emergently as well. That's the paramedic paradox. And paramedics have a lot of time between calls. We have what we like to call a low call volume and a high acuity level. The patients we see are really sick, and some have been sick for a long time before they call us. They wait an awful long time. And community paramedics make house calls. Paramedics make house calls all the time. What I like about community paramedicine is it lets me do the right thing for my patient without having to worry about anything besides my patient. So currently, for instance, I'll give you the diabetic patient who is having a hard time managing their diabetes, and they have a low hypoglycemic episode. And we show up on scene, say, well, Mr. Jones, what's going on? I'm unconscious. I don't know what's happening to me. We check their blood sugar. It's about 30. We start an IV. We give him some D50, and he wakes up magically, miraculous. He wakes up and says, I don't want to go to the hospital. I'm fine. So we call our medical control and say, hey, we fixed this guy, he doesn't want to go to the hospital. So we end up fixing him a peanut butter jelly sandwich and leaving him home with instructions to contact his primary care physician. Doing just a quick real hand survey of all the cards that we had when April asked us, so how many patients do you think you have in each clinic that is hypertensive? And we went with 160 over 90, and we found 15 patients that we don't know whether they have primary care providers or not. There's 16 patients that come into the Sandpoint Senior Center that their blood pressure is routinely over 160 over 90, and in Priest River, we found 5. So that's a pretty good ratio. Patients.
And it's an indication if they're coming in week after week with that reading, they're either not getting treatment or they're not compliant.
Right. So the processes that we're trying to come up with, that like I said, I've developed a couple of forms that I want to use for our blood pressure clinics there, where the patient comes in, sits down. If their blood pressure is 160 over 90, then we ask them, would you like to be enrolled in our pilot project? And our pilot project will entail us finding out, getting their permission, so we're HIPAA compliant, but getting their permission to share information, and then finding out who their primary care provider is, contacting that primary care provider, and then making sure that they're being seen for their hypertension, and then following up with that provider and closing the health code. That's our whole process. That's what this little mini grant's about, is trying to develop that whole process there. And I know we're going to run into some stumbling blocks because, I don't know what data you need. I know what data points we're going to record and keep. But we also want to be able to prove success, that this is successful and that this overall lowers the healthcare costs in the community.
One of the things that we funded is we've purchased 50 of these home blood pressure monitors. And what we intend on doing is giving these to people that we enroll in the program and educating them on their uses. They're pretty simple to use. They go on the wrist, you turn it on, and it needs to go at the level of the heart. There's a sensor on there that tells you when you're at the level of the heart. And as soon as you're at the right place, it starts. And there's a memory, so we would ask them if they're coming into the clinic or we're doing a home visit, we would check the memory and it trends the blood pressures. And then we would take a blood pressure with one of these, or if they had their own, use theirs, so it's the same device taking the pressure. We have a large number of data points over time.
One of the problems with rural areas and doing research is like our STEMI program. We published it, we had 30. Our data set was 30. So we have small data sets for these, and so they aren't widely recognized. But, so that's part of what we're gonna do too.
Just a suggestion from experience. If you go to the senior centers, which is great, that's fine, but it won't get you community support. But if you go to places like Safeway, whatever, then you'll get community support because they'll see you out there. I would just suggest that spread yourself out
Yeah.
to places like Walmart. Makes a big difference.
Oh, yeah. We're even thinking that eventually we'll get referrals from other paramedics. For instance, Ada County right now, they have community paramedics because they got a bunch of resources they can put into this. Plus, it saves them money when they don't have to transport these patients all the time, and because they don't have any insurance, they don't pay their bills, and we do the same thing. So, where we're going with this is not like that. So,
As you expand your program, and I was talking about this at a meeting we were at last week, Medicaid is going to be cutting back significantly. And they're looking at going to a managed care plan, which we've seen with Medicare. And so, while Medicaid is supposed to be accessible to all who qualify, I think in the home health arena particularly, it's not going to be as accessible as the program was intended and legislated to be. And so as time passes, I can see how your program, starting with hypertension and CHF and such, will expand because simply the funding for the services that have been traditionally funded by Medicare and Medicaid are going away.
And the important part is we need to be talking about this as a community, as stakeholders in the health of this community. We need to be talking about this so that we can meet those needs, so we can meet the needs of our population. So you're absolutely right. You're absolutely right. I'm fortunate enough to have been picked to be the chairman of the Governor's EMS Advisory Council on EMS, and we have this MSAC meeting, and we've designed a special subcommittee on nothing but community paramedicine. Since we developed that subcommittee, I've been asked to speak to the Idaho Hospital Association Board of Trustees. I've talked to other hospitals around, and so this is kind of coming now from the top down, and now we're doing this as kind of the grassroots thing, and I think we're going to meet in the middle and just take off. We really need to have community support and the collective knowledge that you have from already doing this stuff and helping us to see where our little puzzle piece fits into this picture so we can help. Because really that's what we want to do, is we want to help.
So we make sure that we have contact information from everyone, because our next step will be contacting you about specifics coming from this, and I think we want to pursue the consultations at the clinics. We want to pursue, I think Safeway is a great idea, Super One. I think we need to expand our horizons for the blood pressure checks.
In October, there's a blood pressure, have you guys heard of this? It's a blood pressure thing. April was telling me about it. In October, there's a bunch of blood pressure clinics all over the place taking blood pressure at the same time or something like that. She wanted to do it here in IC. We'd be happy to participate in something like that. So there's a lot of public things like that too. But I really just don't think that we're going to be I don't think we're going to be lacking referrals for what we can do. My fear is that it's just going to explode. And we're going, okay, here's, like I talked to Dr. Jenkins, just casually talking to him about this. I said, so how many CHF patients do you think that you could utilize a community paramedic visit on? He said, maybe 100. 100? You can't possibly even schedule that many. We have 3 community paramedics doing this, but
I'm hoping we bought 50 of these, and I'm hoping that's enough. They're $50 a piece, so it's not like
That's for partnering, I think, with your program and our programs. we can look at, I think you potentially could have a huge volume, and making sure that person lands in the right place.
Yeah.
And has that need met, and we're gonna have people that we can't serve because they don't qualify. You may have people who are maybe higher level or needing those timed visits or those routine things that maybe it's not gonna be feasible. So it's that partnership of knowing, which patients are you, Amber, which ones are best in your transitional care program on home health and community paramedics, and just really recognizing that and being able to educate the community.
A big part of this, though, and I'm going to just pound my head against it, is we need to measure it and we need to publish it. Those are really important, two important concepts, because it happened to EMS in the 80s. We got a whole bunch of grant money, yay, in the 70s, yay, EMS saves lives, great. And then in the 1980s, everything dried up. All the federal money dried up for it. Well, grants are all over. And so we went into the legislator and said, hey, we need some more money because our EMTs are doing a good job. Oh, really? Prove it.
Yeah, all of our stuff is evidence-based.
We could not prove in the 80s that EMS even saved one life out there. We were totally ignorant of data. And so data is playing a huge role in this, too. So I want to make sure that we are recording the data that we need to do to make sure that we can prove success to this. Because otherwise, the guys with $1 billion aren't even going to listen to us at all. They aren't. I mean, our STEMI project, we learned a little bit from that because it's a great project. We are saving lives like crazy. Other people are modeling the way that we transport STEMI patients and do their heart casts and stuff. And because we had such a small data set, it wasn't really given a whole lot of international recognition.
We didn't have the volume of patients.
Volume, that's what I mean.
But the results were, we had a 40% reduction in hospital stay days after the complication rate went from 45% to 5%. It's a big deal.
Yeah.
And we had, during the program, we had 0 deaths.
0 deaths.
That's all great when you're talking to people like this that are medically oriented, or have a statement. But when you're talking to the guy out in the street, they're looking at their tax bill. And what you guys really need to do is sell yourselves. And I think this blood pressure program is an opportunity to sell yourself.
Yeah.
Appearances are maybe more than content sometimes. They really are.
Yeah.
And that's where, I know, just from experience, when we started out at the bottom, there were no paramedics. And you talk about tough. I was selling the whole program to everybody. What we did, we went out, every time we had a chance, we went out and sat safely, between runs, things like that. Didn't do blood pressure, but we tell them what we can do. And what I'm getting at is, if you get the doctors, the GPs, family practice guys, on board for free blood pressure check or something else, and then when you're doing a blood pressure, all of a sudden you say, well, this guy's got an arrhythmia, he's probably throwing PVCs right and left. Okay, if you've got a list of doctors that are willing to see that patient for blood pressures, and we've only got a couple cardiologists, so you say, okay, look, you got an erratic heartbeat. You're not going to diagnose him out in the field like that. You can say, look, you ought to go see this guy here. He'll look at you. If you get the doctors wound up, I think you might be surprised how much support you'll get, and from the public. I mean, I'd stress the public myself because most people, they see you running around, but they don't have interaction with the real world.
Sure. We're not very good at it, and I know we're not very good at it. I mean, even dealing with it internationally, people do not know what paramedics are capable of. People do not know what we do.
I don't think you're not doing your job, or not doing it, it's like a policeman. The only time you see a policeman is when there's a problem, and that maybe never happens in your life. So I guess what I'm saying is that exposure, especially positive exposure like this, would do wonders for you. the federal money might be out there, but you won't get it if the people here don't want it. And I think right now you need to sell population, say, look, we want that.
Yeah, we need to toot our horns a little bit too.
This is, and have people get to know us face to
Yeah,
face.
just not face to face, yeah.
And I think, I think definitely, the grocery store idea is, in my mind right now, is a done deal. We're gonna do it.
Yeah, we did that at we did a coffee stand for a while. We discovered we were getting a lot of high blood pressure. So
Yeah, I wonder what, like on the rig, free blood pressure doesn't cost you anything to put that on the rig. Free check. Probably won't do it because you're driving around. But if you park at Safeway getting dinner,
We have a sign, what do you call those?
trifold.
Trifold signs we can put out. But, sometimes the simple things we don't think of. And I didn't think of the grocery store thing, and it's a great idea. Thank
Simple
you.
is a good idea.
It's a simple, great idea.
So can I send you, or do you want to look at them on the screen? The format. I have a little format for what the paramedics are going to use at the blood pressure clinic to determine what high blood pressure is, and try and enroll them in this program. And I also have another form that I've been working on that actually has the skill sets of a paramedic and where I think we fit into, or where we think we fit into the primary care health system. So everything from doing, welfare checks on people, to going in and doing 12 EKGs in labs. We even talked about getting an iStat so that we can do labs at home in some of these patients. So there are a lot of things I'll send that to you because that'll give you an idea of what we are capable of, the things that we could do should we enact that section of it. But what do you think about the pilot project format of this that we're going after this as? I'd like to do one pilot project. I can seek funding for it. I've got some contacts to seek funding for it, especially if we're collaborative with a Bonner General, which is a critical access hospital. I know I can talk to Mary Sheridan, and she may turn someone loose to do a specific project, and then we can record it, publish it, and make sure that it's going to be sustainable, and then move on to the next one.
But in front of us is the hypertension
But
project.
in front of us right now is the hypertension project.
And what we'd like to do is send you out materials and meet with the clinics individually and set this up we'll have maybe a maximum of, we'll go out and try to get 50 referrals and divide them amongst the clinics as we get them. And then if you're willing, reconvene this group as stakeholders or an advisory committee. We present our results and you tell us where we're doing it right, where we're missing, and if you're all, I hope you're all willing to do that and to keep us on the right track.
where are the supervisors on this program? I mean our county supervisors.
Oh, you mean the commissioners?
Yeah.
Oh, as long as I don't ask for more money, they're fine with it.
They're
Yeah.
Yeah, as long as you don't ask for money.
Yeah, and I won't be asking them for money.
At some point, you're gonna get down to that probably.
Our county commissioners are very behind all of the things that we've been doing at Bonner County EMS. I feel like I can say that.
Sure, it's true.
They've been totally behind us. And we have Dr. Jenkins, who is also heavily involved in this. He oversees everything that we do. We're not independent practitioners. I mean, we have a lot of skill sets. If you said, start an IV on that person, by golly, I can start an IV on that person. But I need a doctor to tell me.
Yeah, we've actually, our tax revenue went down last year. It's going to go down again this year because we're at the maximum level rate. Property values are going down. So this last fiscal year, we had $100,000 less in tax income, and this year we'll probably take another $100,000 away because of the reduction in property values and our inability to raise our levy rate. It's just, you can't do it where the tax. So,
But
we're spending money.
I didn't want to take more than an hour doing this. I'm already 15 minutes over, so I apologize for that because I know that your time is valuable. But I encourage you, send me an email, call me, and let's talk about these things. I'll send those out for you so you can digest that form first and see if that's a form that would work with your agency. And then let's meet. Okay, let's, after we look at the form, let's meet. I'd like to get some input from you on how we can, how with your organization we can close that healthcare loop there. Okay?
Are there only 3 of you that will go out and try to find these people?
No. Like I said, paramedics, I refer to paramedics as all of our staff. And most of the bulk of the work really is done by advanced EMTs, which are like just one level of training below the paramedic. And so our standard of care right now is actually advanced EMT, meaning that they can show up, do some meds, do an IV, things like that. And paramedics, there are always paramedics on duty here, but we fly around in these chase cars. So we may show up, do what we need to do, or determine that this patient is not a paramedic and an advanced life support patient, and then move on to the next one, so we can spread that paramedic out really thinly. Did that answer your question?
Sort of. I'm just wondering if you need more maybe volunteers that could do the really basic, just go out, find people, fill out forms, anything like that you might need.
We do have a volunteer program that we're kicking off. We've never had volunteers before, and we partner with Sandpoint Fire. And we're going to be, in the next couple of months, we're going to be having a joint open house. We're going to be recruiting volunteers, and that's one of the things that the volunteers can do for us is participate in doing that kind of legwork. So the answer is yes.
There is a volunteer match. I don't know if you know about that. It's a website you can go to, and we use it at the library to get volunteers to do.
Outstanding. Where I have problems sometimes in writing my tools and utilizing the tools that I'm trying to use in educating the public is I use terminology that's unfamiliar with the public, and that's where I would really like you to help us is to review some of the things that we use, like our brochure that we're putting together, and see if it's palatable for what you do. I mean, you get information out to people who are not tech savvy and those kind of things.
We do have, if you're not on it already, a Facebook page that has videos on it, a website that has videos on it, and a YouTube Bonner EMS YouTube channel. So we have lots of informational videos that we've produced in-house, and videos for healthcare providers, and there are also videos for the public. There's one on Dr. Jenkins does on different kinds of chest pain people may experience that they're maybe not aware of.
Could we link that
Absolutely.
website?
Absolutely. There's more to come on the Bonner County EMS, the BonnerEMS.com. There's more to come on that as far as the community paramedicine stuff.
There's a huge group out there of old dogs like me, physicians, all kinds of healthcare people that retired and came up here, all Californians. They're not being touched at all. And a lot of those guys, would be a resource for you guys for training, for advisory stuff, just helping out.
Yeah, I just wish I knew how to reach them.
Well, it's not easy because they're up here because they want to go fishing.
Yeah.
They're out there. Well, we've got a Supreme Court judge right across the river. Now, we go, what do we want a Supreme Court judge for? He's retired, but he'd be invaluable to the program. He really would. He knows everybody in the world. He could look at all the legal things, but he's there. We're not capping these people. I don't know.
Well, I think that you're right that taking steps like being at Safeway and getting people to know what we're trying to do, continuing to produce the videos and getting them out to the public, well, eventually people will become familiar enough with what we're trying to do, and maybe we'll generate some interest that way. Because let's face it, Bonner County EMS publicity has been abysmal it's been in existence since 2006, and it's been abysmal up until maybe the past year. It's been negative. So it's kind of hard to turn that ship around on a dime, but I think we're doing it. Yeah, but it's groups like this, I think, where you're bringing these ideas that we haven't thought of yet are going to we're going to turn the corner and make the difference.
And
it has turned around in 1 year, and I'd like to point out that I've only been employed for 1 year.
Good job, Dave.
So Ada County started out with a stakeholders group of about 10. And now they have 200 in their stakeholders group. They routinely send out information to their stakeholders group, and they get feedback from their stakeholders group. And that's kind of what we're looking for. The stakeholders group like that. So if you see some way that we can be of assistance to you, I want you to let us know. Okay? And
I mean, the message from the state is very, very clear. We'll fund this, but you have to take your direction from the stakeholders group.
right.
You have great ideas, but the direction has to come from the state, from the people that know these patients and know what works and what doesn't work. So that's what we're asking you to do, is give us direction.
And if there are people who you think should be here that you know, let's invite them next time.
You can make it a Tuesday afternoon. Probably Dr. Lawrence will be able to come.
I'm open for any time, really. I'm open for any time so that we can make it. I didn't know.
Oh, he's on vacation.
Yeah. And if we could have it at a different place too. I mean, I know the college because I teach here, so.
If you want doctors, make it 7 o'clock in the morning.
Yeah, they were quite active this morning. I was surprised.
Have a meeting here for half an hour, and they go to work.
That's why you had to be, it's there at 7 o'clock this morning.
Yeah. Well, they also offered breakfast. It was Dr. Healthy stuff. Fruit. Right. So, anyway, from that group, incidentally, the physicians, when I talked to them, there was 3 physicians who gave me feedback, besides Dr. Jenkins, who had been fourth. There was 3 of them. 2 of them said, how can I refer patients to you right now? And the third one said, this sounds like home health to me. Isn't home health already doing this stuff? And I assured them that home health was invited as to be one of our stakeholders too, and we're not here to step on anybody's toes. And I want to make that perfectly clear.
And a mistake that we will not make is taking referrals and dropping the ball. So we want to be very careful with how we're doing this, and we proceed slowly so we don't disappoint any of you with not being able to follow through. We refuse to do that.
I know one thing that'll kill this program instantly for the doctors, kill the program, is if they think you're taking over business from their offices. You know, you can be ancillary, help them, but as soon as they feel a threat, that'll be the end of the program.
One of the first programs that Mark looked into, they got a lot of resistance from home health and the nurses union because it was perceived as a threat to their jobs. So we've taken great pains to be upfront with that we don't want to take any income away from any healthcare professional in the community. And I think what we're going to do is we're going to augment the income by what we're doing.
Yeah, my experience, which has nothing to do with what my past as far as fire department, business experience, is medicine runs on money. That's the way it is. And if you don't believe that, you're going to be in for a surprise. And paramedics, and we've got a hospital person here, and they're under severe stress. It's all money. It's all money. And that's why I say, if you're taking blood pressures and you can refer people to an office, that's going to do more for you. PR, whether they make money or not, almost isn't important. They will. I guarantee it. They will make money. But they're going to have an attitude towards you that's going to be positive. So I would really tie the docs in. I'd get a couple of people together and go hit these guys personally, just smooth the heck out of them and say, look, all you got to do is take a blood pressure. What you do past that, it's up to you.
And I think along with that, for example, the hospital is getting financial penalties for readmissions within 30 days. And we can go out and avoid that for them. They're going to be pretty happy with us. And that's what's going on in Fort Worth is they're reducing the number of readmissions, and the hospital is actually paying them to go out and do these visits because it costs them less than the money that they're saving. So,
What they did was
and I agree with you, it is about dollars and cents.
they shared
Of course, if you
percentages.
forget that, you'll be in for a surprise.
They did, they shared percentages. They said, okay, so if you can do this for a year, we'll measure it and we'll keep track of everything. And if you can do this for a year, we'll give you 20% of whatever they incentivized us with. And they ended up with millions.
Well, you know, in our community here, the doctors, one of the biggest complaints is, you know, we send our patients to a provider, home health, hospice, and I'm speaking from my world, and then we don't see them again. So it's, you know, it's important that, the way you guys are setting this up is great. And then particularly if you're targeting those who can get in to see the doctors. A lot of our patients truly can't. And that's, you know, it's very hard to manage from an office, and they don't get paid to manage from an office. So the more you can partner with them and then get those patients to go in for those visits, the more successful you'll be. And the program you were talking about, where you were talking about where it took work away from home health and such, you know, those days are almost gone in reality with how the healthcare reform is rolling out. There's such a minimal little window of people who can qualify for the services. And, you know, I think those days are on their way out of the competition type of thing. You know, as long as we can partner together for those who truly need the services on a longer term or a more intensive basis, I think it'll work out beautifully.
Are you representing hospice as well?
Yeah.
Because it's just a shame sometimes how many hospice patients we transport. I mean, unnecessarily. Against their wishes, basically. I mean, because there's nothing else.
You know,
I mean, so I'm that's a bad term. I was going to say I'm dying to get into that one, but actually I am excited about getting a pilot project going with hospice and letting us get a little bit more training in that process so that we can help out.
And nobody's happy with that. We show up at the hospital and ER and they're like, what are you guys doing?
Yeah.
You know?
that's- one of the things you might just look into is cancer patients out in the blue ones that have to have regular injections. There's people that do that. But it's huge money. I even thought about doing that business at one time. It's huge. But it falls right in line with what you're talking about. And the payments are just incredible. And you can find out a little more about that. But that's something to at least think about. These people have to have regular medicine. And it's dead simple. You're going out doing an injection. I don't see that.
And they're doing some of that in Ada County as well. They're doing it with DOT, something observed treatment. Something observed treatment. Anyway, so they observe the treatment. To make sure the patient's compliant, to make sure that these things are going on. They go out, they give the patient the medicine, they're done.
There may be situations where it requires a nursing assessment.
Yeah.
And they're inaccessible and we can bring the nurse to the patient.
You can take out a snowmobile.
Yeah. Literally on a snowmobile or a 4x4 and get you safely to a patient.
We'll have to teach you how to rappel.
We've had one situation in 10 years that we actually did seek support to get in from the sheriffs because it was so treacherous and icy and up. We could barely get in. Yeah, but we usually do get in. I mean,
That's our world.
Yeah.
We love that, right, Dave?
We usually, I mean,
Love
we do pretty well getting there, but
So yes, everybody is under the gun as far as money is concerned. It's good to hear that we won't be competing as much anymore, and it is all about the money. The nice thing about a community paramedic program, it adds one more piece of the puzzle, and then if all the pieces work together, regardless of what happens with healthcare, we're going to be stronger overall.
Right. All right, well, that's all I have. I'm sorry. Now I'm 30 minutes over. I'm going to blame the chief. You talk too much.
Okay. Thank you very much.
And please contact me. Go visit our website. Thank you very much for coming.
And like us on Facebook.
thank you. Nice to meet you.
All right, take care. Thanks for, good stuff.
Yeah, it was great stuff. I really appreciate it. Very much.
Thanks,
Sure
Evan.
that connects to
Medical
our
consulting business, so I know the business part.
Well, I think there's incentives.
And we
It's
have
gonna
one
get
in
tough.
Priest River, and we have
It's gonna be a whole lot tougher for
Great Mud.
The collaborative effort. No, no.
Right, right. I know you want.
Yeah.
It's incredible what's going on here.
We need to sit down and get that group, those groups, actually, and figure out
It's gonna affect
a way to.
What I'd like to see,
Because he kind of helps to merge all three of our clinics.
I don't think
Do
you
it
guys
on
could
Tuesday,
do
because he has
it.
Tuesday afternoons off. Even if you want to
Right.
make an appointment,
You can go to him, right?
I'd like
can
to
pop
see it
in, I
make
mean,
a real career.
he probably really open to it, because
You did it.
we're doing patient-centered medical.
It's gonna be there.
Part of our stuff is we have
That's
to
what
do
I'd like to see the
community outreach.
taxpayers.
Yeah, that's what I'd like to see as chief too. It's tough. I mean, we just found out from the commissioners this morning in our 10 o'clock meeting. They met with the insurance company. Our healthcare costs are gonna go up 60%. It looks like 60%. It's gonna go from 9,000 per person to 15,000 per person. And quite frankly, the county doesn't know what to do. It's huge for
That's
EMS.
this next year.
Yeah, that's this next year. That's gonna cost us $150,000. At the same time where I told you I'm getting less tax dollars, got a little bit more transport dollars, but if Medicare makes changes on reimbursement, I could really, we could really be in trouble.
Peter?
They're gonna make changes. I mean, that's.
Desiree is interested in taking on the ERP program.
I don't know the answers, I wish I did, I study
I
this
don't know
crap
how,
all the time,
I've had
trying to see what's going
I
on.
want to do it for a couple of years.
We don't have one of those, we have one that's finishing up right now.
Yeah, we got one that's finishing up right now. We've got a actually medical responder course in Awards for the
Oh,
fall.
we're training paramedics now, 100,000.
And I think we're just trying to get through this first one before we
Wow.
the next one.
You know,
We've been doing them yearly, probably
There's all kinds of guys making 150.
not this fall,
Our
next fall.
paramedics
We're looking
are
at
making a little over
We try to do it in the
40,000.
winter times, but when everybody's just like, there's nothing to do except shovel
I
snow.
don't like when
So,
people say, yeah, but it's North Idaho. It irritates me.
So probably before it
It does.
So where would I find that?
So we're gonna have
Go
it
to
posted on our
Safeway, it's the same
website.
price.
MontgomeryMass.com. I didn't bring any cards.
That doesn't fly.
Slack, but anyway, you can just
Well,
call,
I'm
the office.
gonna really looking forward to working with you. I was hoping that would eventually happen. It looks like it's gonna happen.
No, I just thought something.
You already
different to
did.
do Besides what
I know you're
I.
gonna
I mean, we've talked
Yeah.
pretty honestly about a lot of
I think
things.
Deacon's a good, it's a good class, I mean, she's gonna
I
teach
just-
a little bit about everything.
And Mary said something
Think
about
exposure
kids
to
coming
what
in
you
and
guys
doing some
gotta
like
have.
I
training.
think it's 5 years.
I have one.
Even that program you have, just be enough to.
But
When I was over talking to Mary Lou.
Check out my, on the website, there's a 40-minute video that I did on the system. Could you let me know what you think of it?
I don't know when I'll have to set it up, maybe in the next couple of months.
Thank you.
Because
See if it's
it
right.
reminds me of some of the stuff that needs IVs.
And
I
think
haven't
we
done
can
an
teach
IV in
anybody to
6
do it.
years,
You just
so.
can't be giving these to the coaches or anything like that.
No, but I just want them to be able to learn how to do